today. We're going to go ahead and get rolling as we have a lot to cover. A couple of things to note. Well, first of all, you're here for It's Complicated, implementation questions regarding price, programming, and policies for Descovy as PrEP. This webinar is being recorded, and the slides will be made available on the ABAC website after the call. We are all in mute function right now, so we have a nice clean recording. But if you look at your interface on your screen, when it's time for Q&A and clarifying questions and discussion, you can click on the bottom left and unmute yourself. But for now, please keep yourself muted so we can have a nice, clean, clear recording. I want to start by thanking the folks who pulled this webinar together, including the organizations AVAC, HIVMA, my organization. I'm Jim Pickett, by the way. The Well Project, and WRI, and also our partners from HIVMA, NASTAD, and Johns Hopkins, and AIDS Alabama. We've also had a little change in our presenters due to a number of factors. Our first presenter, David Hardy, has some travel issues and is now in the air as opposed to being on the ground. So we're very grateful for Craig Hendricks from Johns Hopkins, who will be taking over the first section of this webinar, talking about the science between TAF and TDF. He'll be followed by Andrea Waddell from HIVMA, who will be talking about Truvada safety lawsuits. Following Andrea will be Amy and Tim from NASTAD, the dynamic duo, talking about pricing, generics, the 340B program, and other really important issues. And moderating the call today is Kathy Hires from AIDS Alabama, and we're very grateful to have her on board, CEO of AIDS Alabama, and also runs the 340B program and really gets very personally how complex the PrEP landscape has become. I'm going to just say one more word and then turn it over to Kathy. So as you all know, you're on this call. It is very complicated. It's become much more complicated since Descovy was approved. As we know, Descovy and Truvada are both equally effective. Descovy was shown to be non-inferior to Truvada in terms of effectiveness. They have different safety profiles. Not one is better than the other. They have different safety profiles. We'll be talking about some of that. We are in the midst of a landscape that is replete, unfortunately, with lots of misinformation coming out via these Truvada lawsuits. That is really scaring. They're scaring our communities. They're scaring providers. They're scaring people living with HIV, and they're scaring people who use PrEP. And we've seen some real impacts of that. We've seen people who were taking PrEP stop PrEP without talking to their clinician after having seen some disturbing ads on Facebook and then become HIV positive. There's real serious ramifications for this misinformation, and we're going to definitely dive into that. And we're now faced with a really complex funding landscape where we know Truvada will be available generically in about a year from now. We also know that generics will take some time for the price to come down. So once generics come into the market, it won't be an immediate price reduction. They will have issues there. We know that many of our organizations are very reliant on 340B programming and getting rebates from name brand drugs. And rebates for Truvada will no longer exist because it will no longer be a name brand drug in a year. So there's some conflicts there. There will be conflicts of interest in terms of our need for 340B and our similar and a very important need to prescribe to individuals based on their clinical need. Will many of us feel inclined to prescribe Descovy to get our 340B rebate, even if Descovy is not necessarily clinically indicated? I think that's a question to be thinking about. So it's complex, It's complicated, no boring days in this field. Thank you for being here. We're going to dive in. I'm going to turn it over to Kathy Hires, who will be making some comments, and then we will start with our first presenter, Greg Hendricks. Thanks, everybody. Here's to you, Kathy.
All right. Thank you, Jim, and good morning, everyone. Thanks for joining us early on a Monday morning. We certainly do live in interesting times right now. We all face choices every day about Truvada versus Descovy and soon versus generics for PrEP, as well as what I call the 340B conundrum. As a provider at AIDS Alabama, we have 2 PrEP clinics, and I know that we depend on the 340B income to pay for the labs and the costs for our uninsured patients. Yet I also understand the incredible savings that generics could create. So today what we're going to try to do is have some honest and respectful conversations on all of these topics. And if I do say so myself, we've got some really smart folks here to talk about it. So I'm not going to use up our valuable time. I'd like to kick it off first to Dr. Craig Hendricks. Craig?
Thanks very much. Thanks for the invitation. I am going to do my best to channel David Hardy this morning, talking about TAF versus TDF, and I will refer to the 2 drugs as that throughout, to talk about how much of a difference. And I'll say from the start that most of this is going to be a discussion of some of the data regarding adverse effects. There's going to be 2 studies in particular we'll be looking at, and 1 meta-analysis to try to understand the differences that exist. We'll talk about statistical versus clinical significance and the like. So let's go ahead and go to the next slide, please. I won't say much more about PrEP efficacy, but as most of you are certainly well aware, the FDA advisory panel back in August was a split decision for FTAF, for Descovy, in PrEP, with a yes for men, and included in that was transgender women. But there was lack of full consensus for, lack of consensus really at all for cisgender women. And some of the specifics of that, those issues will come up actually in another webinar, I think later this week. So I will move quickly past the issues here. The critical piece is that in the Discover study, they were demonstrated, as Jim already led off, to say they are non-inferior. That is, FTAF was non-inferior to FTDF. Next slide. So the question is, for both PrEP and treatment, do all patients need TAF in combination with M-tricytidine for PrEP, or with more complicated combinations and M-tricytidine for treatment? So next slide, please. So first, to consider the PrEP landscape, this is a global kind of high altitude look at some of the categories of adverse events in the Discover trial. These data are all from either or both the Gilead and FDA briefing documents for the advisory committee meeting back in August. And I wanted to make the point here in a couple of ways. If you look at global categories, and then we have very specific symptoms. These are symptoms that occurred above a certain frequency. And then finally, at the bottom of this table, grade 3 or 4 laboratory abnormalities that occurred in at least 1% of research participants. As we move over, the first column is FTAF and then FTDF. And you see what will be very important in understanding statistics is that there's north of 5,000 participants in this Discover trial, which provides tremendous statistical power to identify differences between the 2 PrEP regimens. And in the third column, I've shown you the difference. This is an absolute percent difference. And as you go down these columns, so we started with the global categories: treatment emergent adverse events, grade 2, 3, or 4 treatment emergent, and I'm sticking at this point with drug-related adverse events based on the investigators in the trial. And then you see the numbers get pretty small very quickly in terms of the drug-related adverse events. You see single digits or fractions of a single digit ranging from 0.1, 0.2, 0.3, all the way up to 3 or 4. And the point I want to make here for these global non-categorized adverse events is that the absolute differences are really trivial. Most of these actually in this global category, not statistically significant. Those numbers you see are very small. I would say it's fair to say there's not any clinically important differences here as well. And then when you get down to specific symptoms, these are mostly GI symptoms here, which are mostly more common, but in small percentages early in the study, in the first month. Here also, there's, some favor one drug, some favor the other. These are really not of much clinical significance, I think, at these frequencies. They're all very low. And then laboratory abnormalities, same kind of picture. Some go one way, some go the other. In that final difference column, there's pluses and minuses that vary. So no clear picture at all. And I think this is very consistent with what Jim was describing at the top about different risk profiles, but really not very much different here. Where the differences start to occur, at least statistically, is when we dig a little bit deeper into some very specific categories, which were of interest because it was in these categories related to renal and bone and perhaps lipid abnormalities that there were some concerns, at least for several of those, with FTDF compared to FTAF. So we'll look at those in the next slide. And here in the first part, you have the renal abnormalities, and these are broken into two groups, really. The first two, serum creatinine and the eGFR, based on Cockcroft-Gault. These are measures of glomerular function. The next four categories are more a measure of tubular function. These are two different parts of the kidneys. They work in tandem, but the mechanisms of toxicity may be somewhat different. There is some of these are related to each other. And the second column over shows you we've got nearly 1 year and then nearly 2 year data for most of these categories. And then we have the percent change for FTAF, percent change for FTDF. And if you compare those numbers, you see that in most cases, with the exception of the urine beta-2 microglobulin and the urine RBP to urine creatinine ratio, these are two of the measures, very sensitive measures of tubular function, that the absolute differences are really very small. Now, in the far column, you see the p-value is significant for almost all of them. But this is the point I want to make here, is that statistical significance is the first pass, and then one needs to make the decision, both physicians, providers, and patients, to decide together what might be clinically important from among these differences. The next category is looking at bone, hip bone mineral density, spine bone mineral density, a bunch of categories of lipids. For the bone mineral density, there are statistically significant differences, but the overall absolute differences are around 1 to 2%. For the lipids, the differences are in the range of anywhere from -0.2, but all the way up to a number of these categories, both at 1 year and 2 years, where it ranges from sort of 5, 6, 7%. But in this case, these are positive numbers indicating that there's possibly an advantage for FTDF. And again, these are all statistically significant. And the numbers I put in there are just globally because these were stated to be statistically significant. I haven't seen a test-by-test comparison there. So the take-home for this is that there's a lot of statistically significant differences in a study with 5,000 participants, but the magnitude of the differences, with a few exceptions, are in the low single digits, if not less than 1%. And I think it's fair to say in the vast majority of those categories, there isn't a clear advantage one way or the other, but there are a few categories worth thinking about in particular clinical cases. That is, there's pre-existing disease, be that renal or bone, or perhaps a cardiac risk factor in terms of the lipids. And those go different ways depending on whether you're talking about FTAF or FTDF. Next slide, please. So now we're going to move into a treatment setting, and this is looking at a study presented just a few months ago, the Mexico City IAS meeting. This is looking specifically at renal function, and this is going to drill down a little bit further into the data. So this is looking at a very useful question, I think, in terms of what happens in terms of renal function as you switch from TDF to TAF. And this was a nationwide cohort study. This is part of the Swiss HIV cohort study presented by Bernard Surial. Next slide, please. So first we look at those individuals that have what would be considered a normal electronic glomerular filtration rate, or eGFR, which you see as the label on the top. The green, as in the rest of this slide, will be TAF. And you see here over 18 months, there was, after switching to TAF, and this was a nationwide cohort study. This is part of the Swiss HIV cohort study presented by Bernard Surial. Next slide, please. So first we look at those individuals that have what would be considered a normal electronic glomerular filtration rate, or eGFR, which you see as the label on the top. The green, as in the rest of this slide, will be TAF. And you see here over 18 months, there was, after switching to TAF, Compared to staying on TDF, there was a reduction of 1.7 mils per minute. I would say this is a pretty trivial change in the GFR, although there were some individuals that had less and some individuals would have had more. Very similar, exactly the same, minus 1.7 mils per minute for those that were on TDF. That's in the population that has normal renal function, no difference. Next slide. In a somewhat lower category, which is still, it's somewhat diminished renal function in terms of reduced glomerular filtration rate, you see that there's a change in the tests here. The TAF group now has, in this somewhat impaired renal function, is now increased 1.5 mils per minute. The TDF group is down, interestingly, a little bit less than the difference before, but there clearly is a difference here statistically. The actual difference is about roughly 2.5 mils per minute in this group. That's a very small change in glomerular filtration rate, but in a group that already has some degree of renal dysfunction, it may be what the physician, the clinician, and the patient might decide is becoming clinically significant to be taken into consideration in a selection of TAF versus TDF. And in the final panel, next slide, you can see there's a much clearer divergence. The difference here is, if I can add them up, this is around 10 mils per minute. But this is in a category of folks that clearly have abnormal renal function. In fact, one would argue that neither of these drugs might be recommended in this category. I think we'll have to see exactly what the final package insert looks like in terms of the recommendation for FTAF or TAF in the combination here. But I think it's a more useful, clinically important, potentially clinically important information here, not just a statistical difference in this abnormal renal function category. One would consider one drug over the other, but even more so, one might consider other drugs entirely to avoid any of the tenofovir prodrugs. Next slide, please. So this is looking at a meta-analysis in a group led by Andrew Hill. And the important points here is there were 9 different clinical studies that compared TAF to TDF for treatment of HIV, and 2 of the 2 studies were for hepatitis B treatment. There was almost 5,000 patients with boosting with either tenofovir or cobicistat in both arms, which covered over 7,000 patient years. And there were somewhat smaller, but still a lot, 3,500 patients receiving unboosted regimens, that is no ritonavir, no cobicistat, with about 3,600 patient years of follow-up. Go to the next slide, and it gives the high points, and then we'll dig into the data just a little bit before we move on. Next slide. So the conclusion from this, and we'll look at the data in a moment, but I think the take home here is that TDF that's boosted with either of the drugs, boosting drugs, was associated with a couple things: higher risks of bone and renal adverse events. And in this study, these were not simply laboratory changes in all cases, but these were actually some clinical differences, and lower HIV RNA suppression rates compared with TAF in the regimen. This is in the boosted regimen. Importantly, in contrast, when ritonavir and cobicistat were not used, there were no efficacy differences between the 2 tenofovir prodrugs, and there were marginal differences in safety. We'll look at these in some detail. In fact, there were no statistically significant differences in most of the categories that we just looked at previously for the use of these drugs in PrEP. And the conclusion then from the authors, the health economic value of TAF versus low-cost generic TDF may be limited when these drugs are used without COVID or ritonavir. Next slide, we'll take a little closer look at the data. So first, this is looking at the 10 milligrams TAF versus boosted TDF. And you see that the top we have efficacy, and then in the middle we have grade, different grades of adverse events, lab abnormalities, and then we have bone fractures, and we have discontinuation for bone adverse events or discontinuation for renal adverse events. So kind of those global values, kind of general clinical categories, and then bone specifically and renal specifically. And the only thing that shows up as statistically significant in this study, which really is of similar size to Discover, is that the HIV RNA difference is statistically significant, about 2%. And then there's about a 1% difference favoring TAF FTC with statistically significant p-values. This is in the boosted setting. Next slide, we look at the unboosted setting with 25 milligrams of TAF versus unboosted TDF. And here you see no difference in RNA change and no difference in any of the safety categories here, in particular bone fractures, discontinuation for bone adverse events, or discontinuation for renal adverse events. So the difference in the treatment setting is that we lose those statistically significant differences that we saw, although with very small changes, in Discover in a PrEP setting, and in a treatment setting without the boosting, there's really no differences here that are identified. In the next slide, I'll summarize the main points here. I think the most important is it's important to establish statistically significant differences as the first step, but then one needs to make a tailored clinical decision in terms of what is clinically important for an individual patient based on pre-existing disease, perhaps concomitant medications, or risks for future disease that might put one drug or the other in favor. Almost all of the important event frequencies are really very small. There were a few categorical differences, I would say renal tubular changes that I think need more work to understand the importance of the thresholds that were chosen in those analyses. Nearly all of the FTAF versus FTDF differences are even smaller than the event frequencies because they were, again, very small differences between the two. Boosted FTAF had more consistent advantages than FTDF in the boosted treatment setting. And finally, again, to reiterate the most important point, clinicians and patients need to consider those occasional, possibly rare clinical situations where FTAF would have very clear advantages over FTDF in either a PrEP or a treatment setting. But one would have to consider the specific risks, whether it's renal or bone or lipid abnormalities, that would lean one toward TAF or TDF, depending on that clinical situation. And at that point, I'll stop and pass it back to the moderators.
All right, great. Thank you so much. In general, we're going to take questions at the end to make sure that all of our speakers have time. But if you do have any clarifying questions, I believe Jim gave instructions on how to talk to us through the chat room. So thank you so much, Dr. Hendricks. And now we have the always fabulous Andrea Waddell.
Thank you so much, Kathy. And good morning, everyone. My name is Andrea Waddell, and I'm the Executive Director of the HIV Medicine Association. And we are one of the groups that represents HIV clinicians and researchers really working across the U.S. Our immediate past chair, Dr. Hardy, was really sorry he wasn't able to participate in today's session, but he asked me to cover a little bit, share a little bit about HIVMA's response to the Truvada lawsuit ads, and that of some others in the medical community, at least the groups that we've been working with. Next slide, please. So at the risk of helping to disseminate misinformation, I will just share these briefly, but we thought it was important for those who may not have seen them to know what we were referring to when we talked about the Truvada lawsuit ads that are on Facebook and on other outlets, including television, as I understand it, and really promoting and misleading information about the potential harms of Truvada for PrEP. So next slide, please. I'll quickly move on from those. But so HIVMA got involved because we started hearing earlier this summer from members who were very concerned because patients were coming into their clinics asking questions about PrEP, wanting to stop PrEP or reconsidering starting PrEP. And when the clinician asked about where their concerns were coming from, it was because they had seen some ads on Facebook regarding the lawsuit. So after hearing from a couple members, we checked in a little bit more widely with members, and this was happening in many clinics. In particular in the southern U.S., and that's where we really heard the greatest concerns about sort of the lasting impact or the longer-term impact that the ads could have on really helping to fuel a mistrust in the healthcare system, in HIV treatments generally. And so really we thought it was important to do what we could to put out some information responding to the ads and raising concerns about the ads. So in early August, Dr. Hardy published an opinion piece with Dr. Margaret Hoffman-Terry, who is the chair of the American Academy of HIV Medicine, really laying out the concerns from the two groups, the potential harms that could be caused if these ads continue, as well as really urging messaging, the top line message was urging for individuals to talk with their healthcare providers when they did have questions about the medications they were taking for prevention or treatment, certainly before stopping any treatment, any medications for prevention or treatment. And as on the same day that our piece was published, Dr. Corey Bloom with Howard Brown Community Health Center in Chicago also published a really terrific and practical piece that really lays out talking points that could be used by both HIV clinical staff, but also other staff or other individuals who are interacting with patients or prospective patients who may have seen the ads, really providing some ways to respond and provide more factual information on the issues that are being raised in the ads. Later in August, the body did a fairly comprehensive piece, really looking at the genesis of the ads, but also really taking a look at what some of the broader implications could be for public health, particularly at a time when we're looking, there's a concerted effort to expand access to PrEP, and we have opportunities like the USPSTF Grade A recommendation going online, and that you're going to hear a lot more about from Amy and Tim. So next slide, please. So I just thought it'd be helpful to summarize some of the concerns, and I can't say that this reflects everyone in the HIV clinical or public health community, but these are the concerns certainly that we've heard by the groups that we work with. First, at the top was really concerned that the legal community was starting to have an influence on clinical care, both for prevention and treatment, and so wanting to drive home the message that really you should seek medical care advice from your healthcare provider and not from lawyers. Along with that, really highlighting the need for people living with HIV and those who are considering taking PrEP to consult with their healthcare providers before taking any action to stop their treatment or prevention, or if they have any concerns about questions about starting PrEP. I will say that the bigger concerns we heard about were from providers who are worried about individuals who were not yet connected to a healthcare provider or did not have a regular healthcare provider and may rethink engaging with the healthcare system in terms of both seeking PrEP or treatment if they've been recently diagnosed. We found that providers were hearing that although the ads were really targeting Truvada, that they were hearing questions from patients about other HIV treatment generally and the safety of that treatment. In the HIV community, we're very lucky to have federal treatment guidelines for both prevention and treatment, or federal guidelines for both prevention and treatment that are reviewed and updated on a fairly regular basis. So we think it's important to really highlight that those are recognized as a standard for care in the U.S. Many of us advocate for coverage according to those guidelines because they play such an important role in guiding HIV prevention and treatment. So we think it's important to continue to educate broadly on the value of those guidelines and really following those guidelines, which really do promote the individualized treatment that Dr. Hendricks referred to. As many of us are advocates or play various roles within the HIV healthcare provider system, delivery system, I think we all have a role in helping to prevent the ads from undermining public health. With the federal HIV initiative to end HIV as an epidemic, we've seen it provides a really enormous opportunity to educate policymakers, the general public, on PrEP and the effectiveness of PrEP among individuals who previously, really hadn't shown an interest. In addition to that, there's this, pretty fairly, hopefully at some point, significant resources that will be invested in expanding access to PrEP, and really attention to how we can implement that effectively to help ensure that the people who are key populations that really need it are not left behind. So it's the timing of these ads in some ways could not be worse. So just hoping that all of us in the HIV community broadly can really work together to really promote to promote the factual information, the information that Dr. Hendricks provided, and that you'll be hearing about more from Amy and Tim as well. So if you haven't checked out the resources I highlighted, I'd highly encourage you to do that. There's a lot of good information in all three of them. So Kathy, with that, I will stop and turn it back to you.
All right. Thank you very much, Andrea. As always, very good. Okay, and I believe next we have our NASDAQ crew, two really smart people, Tim Horne and Amy Killalay. So I'm not sure which one of you are going first, but please take it away.
Great. Hi, everyone. This is Tim Horne. I am the Director of Medication Access and Pricing at NASDAQ. And I just want to start by thanking Kathy and Dr. Hendricks and Andrea for helping to set the stage around and sort of like putting this discussion in the clinical context. And I think what Amy and I would really like to talk about today is the intersection of PrEP medication pricing and the ways in which we finance PrEP infrastructure and service delivery in the United States. First slide, please. Okay, so we know that PrEP is more than just a pill, and that people vulnerable to HIV infection need to be fully engaged in preventive care and supported to improve adherence to remain HIV negative. And this requires PrEP programs to adopt and strengthen a variety of administrative and programmatic services, particularly those that get at the social and structural barriers to PrEP and preventive care in the United States. Now, funding for PrEP services really does involve a patchwork, and some services, can be billed to insured clients, public or private health plans, things like labs, provider follow-up visits, and the cost of the medication itself. Now, many other services, including those for uninsured patients, can be covered by federal, state, or even local government funds. Next slide, please. Now, another aspect of PrEP program financing is the 340B drug pricing program. And 340B not only allows safety net providers, community health centers, for example, the ability to procure expensive prescription drugs at discounted prices to contain cost, but also to generate revenue, quote unquote, to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. Next slide, please. So how does the 340B drug pricing program work? Essentially, it allows certain safety net providers in the 50 states, the District of Columbia, and territories to purchase prescription drugs at discounted prices. For uninsured clients, the lower price means a significant reduction in the cost of the medication to the safety net provider or the patient. Now, no less important is the benefit that comes from insured patients. Here, the safety net provider purchases the drug at the discounted price, but bills the patient's insurance at the usual reimbursement rate, which can be significantly higher than the discounted price. And it is the difference between the discounted purchase price and the insurance reimbursement rate that becomes revenue or program income for the safety net provider. And this program income helps to defray medication, lab, and office visit costs for insured clients. It also helps to build out and sustain many of the PrEP services offered by safety net providers. And these include services that might not be covered by insurers and require more dollars than can be secured by federal funds. Next slide, please. So how does it work exactly? It's somewhat complicated, largely due to the fact that that 340B pricing is part of an incredibly complex and opaque system of drug pricing in the United States. Now, I'm not going to go into this today, but depicted here are the flows of different discounts, rebates, and other price concessions that occur in the various major markets in the United States. Now, one thing to note on the left is that the same federal formula used to determine net Medicaid pricing is used to determine how much of a discount to offer to safety net providers participating in the 340B program. And in short, 340B entities receive at the very least a 23.1% discount off of the average prices in major segments of the private market. Additionally, every time a drug takes a price increase that exceeds the rate of inflation, which is the consumer price index for all urban consumers, an additional discount is added to the base discount of 23.1%. Next slide. Okay, so here are the basic elements of the 340B program for safety net providers, also known as 340B covered entities. So the WAC, or the wholesale acquisition cost, your price approximates the full price of a drug. Now, once both the unit rebate amount of 23.1% plus the inflation penalties are applied, the discounted price available to safety net providers is known as the 340B ceiling price. Now, something to note here is that manufacturers can provide safety net providers with additional voluntary discounting, so outside of what the law requires. So the difference between the list price of the drug and the 340B ceiling price is the discount. And the difference between the 340B ceiling price and the payment received from an insurer is the program income minus pharmacy dispensing and administrative fees. Next slide. Okay, so here's just a snapshot of the various safety net providers that may qualify for the 340B program. And what I've highlighted here are the various providers that are known to provide PrEP in the United States, notably federally qualified health centers, which include community health centers, disproportionate share hospitals, Title X family planning clinics, and STD clinics. Next slide. Okay, so what I want to do here is I just want to show what happens with the 340B program income over time on a single drug. So when a drug is first launched, say at $100 per tablet, it is only subject to the unit rebate amount of 23.1%. 4 years later, the price may be 40% higher, so it's gone from $100 to $140. So the unit rebate amount is higher, and because the 40% price increase is substantially higher than the rate of inflation, additional discounting is required, and the potential for more substantial program income grows. And by year 8, for example, at a list price that may be 75% higher than the launch price, 340B discounting and potential program increases further. And this is synonymous with what we've seen with Truvada for PrEP. Truvada has been subject to significant year-over-year price increases, which has allowed for safety net providers to purchase it at a substantially discounted price and, at least on behalf of insured clients, yield significant program income. Next slide, please. So what can affect program income? First, any legislation or regulations that lowers list prices and prices in the private market can have a significant impact on program income. Also, any legislation or regulation that alters 340B pricing program itself can impact program income. Now, something else to note is that payers, notably commercial insurance plans, aren't particularly keen on making full payments on drugs that have been purchased at discounted prices. So there is interest, at least amongst commercial insurers and the pharmacy benefit managers, in public and private policies that potentially cap payments to 340B entities. Also, healthy competition between brand name drugs also can impact 340B discounting and subsequently, program income. And we've seen this in the hepatitis C treatment space. Finally, there are patent cliffs and the commercialization of generic drugs. Gilead's Truvada, for example, will face its first generic competitor in September of 2020, which Jim alluded to at the start of the program, with several generic contenders entering the market in the spring of 2021. Next slide, please. So what happens when new and generic products for PrEP enter the market? I just wanted to walk you through some examples here. And I just want to point out that these are estimates, and I really just want to sort of walk through this for illustrative purposes. So these are the actual, per tablet list prices for Truvada on the far left and Descovy to its immediate right. And what I'm including here is co-formulated TDF3TC, which is not approved for PrEP, but does make for an interesting price comparison, which is in the middle, which does have a list price that is significantly lower than Truvada or Descovy. Then we have an estimated list price for the first generic formulation of TDF-FTC that will be available around this time next year. Now, as there will only be one generic product until there is more robust generic competition in 2021, the list price may only be 10% or so lower than that for Truvada or Descovy. And finally, once there is robust competition, the price of generic TDF-FTC may fall considerably, and these tend to be around 90% below the average prices for the brand name competitors. And so in this case, I'm using an estimate of around $3.50 per tablet. Next slide, please. So what does 340B look like? Now, with Truvada, the price has increased by roughly 175% since it was launched in 2006. So the 340B discounting and program income here is significant. Now, with Descovy, which was approved much more recently, the 340B ceiling price is actually much higher compared with Truvada. However, we know that the manufacturer is selling Descovy to safety net providers with additional voluntary discounts to achieve 340B pricing parity with Truvada. Now, this has certainly helped to move people off of Truvada and onto Descovy, particularly amongst our safety net providers. So once we start to get with TDF and 3TC, even though it has a lower list price, it's a new drug and we're not aware of any voluntary discounting. In turn, it is technically more expensive for safety net providers with the potential for less program income. And when we have a single generic, the same holds true. And one thing I'll note here is that while brand name drugs are subject to a base discount of 23.1%, the discount is only 13% for generic drugs. And once we have robust generic competition, the potential for cost savings across the U.S. healthcare system is huge, including safety net providers. However, the lower price and the lower reimbursement rates will translate into substantial reductions in program income. Next slide. Okay, so finally, here's a breakdown of what this means on a monthly basis per prescription. Now, again, these are for illustrative purposes. These are not like your numbers that are absolute. So I just want to use these as examples based on back of the envelope calculations using roughly estimated numbers. And as you can see, generic TDF-FTC competition will likely result in significant cost savings. And again, the importance of this cannot be overstated. But this will also impact program income for 340B covered entities. At present, many safety net providers may be generating anywhere from like $12,000 to $15,000 per year on every insured patient filling scripts for Truvada through their 340B pharmacies. And this adds up to substantial amounts of program income flowing back to safety net providers to support their PrEP programs. And even though Descovy is subject to the same discounting and potential program income, Amy's going to walk us through some of the policy changes on the horizon that may make program income significantly less accessible with Descovy, and the need for all of us to think about how to make our PrEP programs whole as a result. So with that, I will turn this over to Amy.
Terrific. Thanks, Tim, and hi, everyone. So next slide, please. So as Tim said, I'm going to talk a bit about the coverage implications of this dynamic PrEP market that we have. We have a natural progression to generic TDF-FTC, and Tim talked about the significant 340B implications of that. But we also have a series of policy choices that will impact the ability of the advent of generics to actually bring down the price of PrEP. So I'm going to talk about a couple of those. And the first one I'm going to talk about is the U.S. Preventative Services Task Force. And actually, we have moved from draft. This should be final grade A recommendation for PrEP. So this was really an exciting moment for PrEP access. USPSTF tends to move very slowly and deliberately, and over the course of years in their review of clinical evidence, released grade A, the highest grade, indicating the highest degree of sort of impact of the intervention for PrEP. And the implications of this are a couple-fold. Number one, the USPSTF is a sort of recognized body for neutral, clinically based recommendations, and so that carries a lot of weight in terms of physician willingness, clinician willingness to prescribe PrEP. But the ACA actually put in place very concrete coverage and cost-sharing requirements that apply to USPSTF A and B rated services. So the ACA mandates that the majority of private insurance plans and Medicaid expansion programs cover USPSTF A and B rated services at no cost to the consumer. So in the private insurance market, that's huge. That means no cost sharing, and we'll talk about what all services, but no cost sharing for PrEP. In terms of the timeline for this, so the final recommendation from USPSTF came out earlier this year in June. Plans have a little bit of lead time to adopt the coverage and cost sharing requirements. So the plans have to adopt the coverage and cost sharing pieces in the plan year that begins at least 1 year following the final USPSTF recommendation. So for the majority of private plans, and there will be some employer plans that come online across 2020, but for the individual market ACA compliant plans, that's going to mean a January, and for Medicaid expansion, that's going to mean a January 2021 start date. So that's around the corner, and we've got some time to do some advocacy work on this. Next slide. So we've got some sort of vague pieces of the recommendation, and I think it's important at the outset to kind of know what the USPSTF recommendations are and are not. As I said, historically, this is a body that is very much independent and was not connected to coverage and cost sharing pieces, and in fact, very straightforwardly does not consider cost when it comes up with its recommendations. It is a sole review of clinical evidence. And so, because of that, or partly because of that, the recommendations themselves are not written for payers. So even though we have this really significant implication for payers in terms of coverage and cost sharing now because of the ACA, the recommendations themselves do not make it very clear in terms of how payers should interpret that. And we see that with the USPSTF recommendation for PrEP. And so, I want to talk about two areas in particular where, the language itself and the recommendation may lead to variable interpretation by payers. And one is access to the medication itself. It's somewhat unprecedented in that I have not been able to find a precedent, but if you all have a corollary, let me know. A situation where you have a USPSTF final recommendation coming out at a point in time where, in June of 2019, we had one FDA-approved medication on the market, PrEP, that was Truvada. But in January 2021, when the vast majority of plans and Medicaid expansion programs have to implement the coverage and cost sharing requirements, we will have multiple products for PrEP, including the first generic that will come online in September 2020. And now, just as of very recently, we have Descovy with an FDA approval for PrEP too. So that in and of itself is somewhat confusing. And the language of the USPSTF recommendation does not provide a whole lot of light in terms of how it should be interpreted in a different time with multiple medications for PrEP. And so, I think one thing that the advocacy community has argued, in the HIV Healthcare Access Working Group has just sent a series of letters, is that the recommendation itself needs to be interpreted as individuals have to be able to access the clinically recommended regimen for them. And that means that the clinically recommended medication, whether right now it's Truvada or for some people Descovy, has to be available without cost sharing pursuant to the USPSTF recommendation. And importantly, that is not a push for open formulary, open access to everything without cost sharing. That really is grounded in what is clinically recommended for the individual. And so, as we just heard from Dr. Hendricks, Descovy may be appropriate for folks with kidney or bone disease, and potentially also off-label use for cisgender women. But Truvada may be appropriate for the vast majority of folks who don't have an indication for Descovy. So that is the sort of advocacy push, and I think from our conversations, it sounds like plans are also sort of going in that direction. And I would just say that the stakes are pretty high here because we're talking about a large swath of the private insurance and Medicaid markets who are subject to USPSTF. And when I say the stakes are high, for what we're pushing and what those markets do, we have the potential to inadvertently undermine the generic market by making policy decisions that sway too far in one direction and that aren't sort of grounded in clinical evidence and recommendations. And that's really important. And so, and this is particularly true, you know, for increasing access via public health channels. We believe the generic market will help increase that. So, you know, we've really been in our advocacy, and I think we'll continue to do so, is to balance this sort of the access based on clinical recommendations with increasing access to PrEP as a whole. So, you know, the other piece of the access to the medication is utilization management. There's always potential for utilization management to be used in discriminatory ways, to be used in ways that sort of solely limit access without grounding in clinical recommendations. And so we're very aware that there's been a history of private insurance utilization management used to sort of undermine the increasing access to PrEP. And so, you know, our focus here is to really ensure that regulators prohibit use of particularly prior authorization as a way to identify folks who are eligible for PrEP or identify risk for HIV. That is sort of fraught with potentially stigmatizing policies, potentially discriminatory policies, and really should be left solely between the prescriber and the patient. So we've come out very clearly on that. I think, you know, where some of the argument, some of the discussion about what makes sense in terms of just sort of efficient policy is how you determine whether someone needs Descovy or not, and what does that process look like. And so it could be something like a prior authorization light, or it could be more of an automated approval process. I think we would argue that we need as streamlined a process as possible to reduce burden on both the provider and the patient. And so the other piece of where the USPSTF recommendation is vague and potentially you know, could lead to variable interpretation is this sort of existential question of what is PrEP. And I think, you know, everyone on this line and certainly according to the CDC guidelines understands PrEP to be not just the medication, but all of the ancillary services that are integral to the PrEP intervention, and that includes lab tests and clinical visits that are recommended every 3 months and recommended very explicitly in the CDC guidelines. We had asked during the comment period for the USPSTF recommendation for that piece of the recommendation of what all the clinical and lab visits, what all they are, and that they are an integral part of the PrEP intervention, for that to be explicitly sort of stated in the recommendation. That didn't happen. It's still rather vague in the recommendation, and we are hearing from plans that their interpretation is also very variable on what exactly they are required to cover without cost sharing. So this is another, I think, advocacy point. We have argued that it really has to be inclusive of all of the lab tests and clinical visit costs, and we have an enumerated list that need to be covered without cost sharing. So next slide. So in terms of next steps, you know, so I went through some of the pieces of the recommendation that are particularly vague and leave room for interpretation. And so what I think is going to be really important is to push both federal regulators and state regulators to clear up that confusion and make sure that plans are on notice as to what exactly they have to cover, under what circumstances, and without cost sharing. And so in terms of at the federal level, you know, we have asked and will continue to have discussions with folks at CSIO. So that is the branch of CMS that regulates and oversees the ACA private insurance market, so your individual, small group, and large group plans that are subject to ACA requirements. And then the Center for Medicaid and CHIP Services at CMS, so the division within CMS that oversees the Medicaid programs that are subject to USPSTF. So we have asked for them to come out with sub-regulatory guidance that would really put, you know, all of the private insurance plans and Medicaid agencies and plans on notice about what appropriate implementation looks like, what they need to cover without cost sharing. And we're happy to share those advocacy letters for anyone who wants them. And then at the state level, and I really have to underscore, this is really important because, you know, the wheels of federal sub-regulatory guidance move slowly and sometimes don't move at all. But there's been more appetite, at least among some states, to do a little bit more in terms of state regulation, state guidance, to really push plans to fully implement PrEP access and the USPSTF recommendation. And so even if the feds do nothing, state insurance regulators could issue bulletins and other guidance that interpret the USPSTF recommendation in, you know, the way that we think it should be interpreted. That includes, you know, all of the lab tests and clinic visits and the medication considerations that we talked about. So that's a really big advocacy point, and we've got a template letter if folks want to adapt it for advocacy with your own insurance regulators. I'm happy to share that as well. And then, you know, just to overlook it, we've been talking about the coverage and cost sharing pieces and financing pieces of PrEP. There's obviously a whole host of other barriers that have kept PrEP uptake in this country really, really low. And so USPSTF, the recommendation, I think, does offer some momentum behind provider and consumer education to really ensure that we're maximizing this opportunity, and we're using the momentum to increase, particularly at the provider level, sort of education about PrEP and willingness to prescribe PrEP. Next slide. So the other big piece in the PrEP sort of landscape that's moving that I want to talk about is the PrEP donation program. And I'm not going to go into so much detail, because I'm going to just at the outset say that HHS has announced a webinar for this Friday afternoon, November 15th. I believe it's at 2 p.m. Eastern. And I think a lot will be revealed on that webinar. So I want to push everybody to go to that. I think we'll all learn sort of how the pieces are supposed to fit in. But very briefly, because I think this is an important kind of side conversation happening as we talk about some of the major health systems and how they're dealing with PrEP access and financing. You've got this kind of new program popping up that I think has potential to impact all of the other markets that we're talking about. So PrEP access, obviously a pillar of the Ending the Epidemic initiative. And as part of the PrEP access pillar, Gilead early on committed to provide PrEP medication for up to 200,000 people a year for up to 11 years. This is a commitment to donate Truvada and Descovy. So the commitment was made before Descovy was approved, but with the intention that once Descovy was approved, that would be part of the donation program. So Gilead has agreed to bear the cost for the medication itself, reimbursing pharmacies or backfilling pharmacies for the PrEP medication. Next slide. So, you know, what has moved rather recently, and I would urge folks to see the FAQ that was recently posted on HHS that kind of walks through some of the early pieces. So Gilead had agreed to donate the medication, and there was still a question of like, okay, we've got the medication, now how do we get it in the hands of people? So there was a sole source contract that was awarded to Gilead, a 6-month contract for $6 million to provide PrEP, so first Truvada and now Descovy, for in that first 6 months, 4,250 uninsured patients. And so, you know, with that contract, I think the word is, you know, there was a tremendous push to get this up and running quickly. And with the sole source contract, this was sort of a way that this could be put in place very, very quickly. And following the 6-month period, there is intention to hold a full and open competition. But for right now, you've got a 6-month contract where Gilead is using its vendors to sort of implement delivery of this new sort of PrEP donation program. And HHS is working on the back end to cover the cost of verifying eligibility, enrollment, building the network of participating pharmacies. And again, November 15th, the webinar, these are sort of the bullet points. I think, at least for me, it's still a little bit murky about how all this kind of rolls out. And next slide. And part of the murkiness is that, as we all know, Gilead already has a patient assistance program for uninsured folks who need access to PrEP. And so I think a lot of the questions that certainly NASDAQ's been getting from its members are, how is this different from that, and how does it sort of overlay on top of that? You know, one big piece of eligibility is that patients who are currently enrolled or have been enrolled in the last 12 months in the Gilead Medication Assistance Program can't enroll in this new HHS program. And The reason is pretty obvious. Certainly you don't want a kind of push from an existing program onto a new program because that's a bit smoke and mirrors. But I think in practice, that's a little bit confusing at the ground level of how that screening happens and how it happens in a way that's not confusing for providers and for patients. So the last thing I'll say about this is that in addition to the PrEP donation program, there's also been an award to a contractor to develop an education and awareness campaign to really maximize the impact. And so those efforts are starting up now as well. So next slide. So I just want to close out here by, sort of underscoring that if our goal, and I would argue this should be our goal, but if our goal is to really create an integrated one-stop delivery model for PrEP, we're kind of going in the wrong direction. We're adding a new PrEP program, overlaying onto existing systems with this Gilead donation program with different eligibility criteria than the Gilead existing patient assistance program. So while that has potential to increase access because we're adding a program, it also has potential to increase confusion. We also have this very patchworky system that kind of bifurcates or separates sort of these three buckets of drug access. You've got a set of payers that are different for uninsured and insured folks. PrEP clinical visits and lab costs, still a real conundrum about how to pay for these, particularly for uninsured folks. And then in that red, the big question mark is, what's CDC going to do? They haven't released their ending the epidemic notice of funding opportunity to CDC grantees yet for implementation of ETE activities. That's set to come out any day now. And the big question mark is, are they going to loosen up some of the restrictions they've had on using CDC funding for clinical visits and lab costs? Question mark. Hopefully, yes, but who knows? And then the counseling and linking services, those are also sort of funded by a patchwork of sort of incomplete programs. And I think this is important because, and this may be controversial, so if folks have other thoughts on this, let me know. But I think, from my vantage point, likely the single most important variable to push integration will be generic PrEP. So it sort of comes back to how are we ensuring that we are not inadvertently undermining the generic PrEP market. We're preparing our 340B systems for the generic PrEP market so that we've got sustainable systems in place. But that, I think, is the sort of single most kind of X factor that once we've got full competition, I think we'll be able to actually design programs that are far less patchworky and far more integrated. So next slide. So I'm going to end with sort of a summary of these points before we open it up for Q&A and discussion. I think number one, first and foremost, generic TDF FTC poses many opportunities to really create sustainable systems of care and access for this biomedical prevention tool. And I think on the flip side of that, generic competition also poses challenges for financing models that have been very dependent on 340B. And it's interesting, Tim mentioned some of the, the federal policies that will impact list prices. And I know that there's some debate about should we push something that will impact list prices and then potentially destabilize 340B. Well, generic competition is coming no matter what. Like that is here. And so this really poses a very real and a strict timeline to really think about sustainability of 340B entities. We talked about the USPSTF recommendation, and really that's an opportunity to, I think, get us as a community really get consensus behind balancing, ethical considerations, clinical considerations, and sustainability considerations in a really concrete way that I think will be applicable not just to PrEP, but to the entire HIV prevention and treatment space. And then finally, with the advent of TAF FTC, we are unequivocal in that it even with our sustainability concerns, that intervention must be available with the same cost-sharing protections for individuals for whom it is indicated based on clinical recommendations and judgment. That is sort of we are unwavering in that. So with that, I will turn it back over to Kathy.
All right. Thank you so much, Amy and Tim. That was great. We've had a lot of activity in our chat room as anticipated, including if anyone's interested in the PrEP webinar on Friday. We have a link for that webinar on there. And We've got several questions, and I believe Anna Forbes has some information that she wanted to share with the group. Anna, you want to go? Do you know how to unmute, Anna? So, okay, I guess Anna is either.
Kathy, I can,
Okay, go ahead,
is that
Jim.
you, Anna?
No, this is Andrea. I was going to promote the fact sheet too, but go ahead.
Okay, I was just, yeah, we're all looking to promote this fact sheet. So in case folks haven't seen it, the American Academy of HIV Medicine put out a very nice fact sheet around the lawsuits and Truvada safety, addressing the misinformation in very simple language, really designed for consumers. Anna's going to share that with us, so we can send that out when we follow up with the, we can have that posted with the slides and the recording on the AVAC website. So thank you very much for that, Anna.
Perfect.
I'm going to, and Kathy, I'll start a question from Mitchell. And Mitchell, I think you're also promoted, so you should have no problem asking questions, but I'll get this going. Mitchell asked earlier, I think this would be great for Tim and Amy. Is there a sense of how many U.S. PrEP users are getting PrEP via the safety net providers versus the Gilead Medication Assistance Program or other types of providers?
Thank you, Jim. That is a great question, and I am afraid at this point it is still largely unknown. I think NASDAQ is very much committed to sort of like mining the data and just trying to get a better sense in terms of where the utilization is, and importantly, where 340B program income might be generated. But we just don't have those data available now. But I think we're starting to make some headway there. And I think the one thing that we've learned is that there are 900 community health centers in the United States that are using their 340B their 340B entity status to procure and distribute PrEP to individuals vulnerable for HIV infection in the United States. So I think we can sort of extrapolate something there. So within those 900 entities, if we assume that just one insured 340B eligible client is receiving their PrEP through that clinic. So one times 900, so we have 900, and if just one of them are receiving PrEP for a full year and the 340B program income is being generated, so at $15,000 per year in program income per individual, that translates to like $13.5 million in program income just on those 900 individuals alone, and that I think that we can say that a much larger number of people are using the 340B entity status to generate program income. We just don't know what those numbers are, because I think while we can start to drill down on the number of people that are using community health centers and other 340B entities, not all of those individuals are actually using the 340B pharmacy to fill their medications. So we still have a lot of drilling down to do there. And with respect to the medication assistance program, we don't have any solid numbers there either. As Gilead has been very, sort of like close-lipped about how many individuals are currently using their medication assistance program or who have ever used it, at least since Truvada was first approved for PrEP. So we're still dealing with a number of unknown variables here.
Thank you, Tim. I see another question from Matt Pagnotti about the impact of the possible HHS lawsuit. Does anyone have any information or comments on that?
The only thing say is that, with respect to the lawsuit, that lawsuits take a considerable amount of time to work their way through the courts. So figuring out how, this will, potentially impact, sort of our current needs, particularly as we sort of go over the Truvada patent cliffs and so on and so forth, it's very, very difficult to say, because I think that, any sort of decision that would come out of the lawsuits would really come, would come several years down the pike.
Thank you, Tim.
And Kathy, I have a couple of comments I can read that came earlier just to include in the conversation, if you don't mind.
Great, go for it.
So this is coming from Christine Brennan, and it's regarding the other lawsuit. So what Tim was just referring to is the HHS versus Gilead lawsuit around the patents for PrEP. These are regarding the specious Truvada safety lawsuits. And Christine says, just my thought is I am coming from a provider education viewpoint. There is some clinical education that is not industry supported that is strongly encouraging not to prescribe TDF-based PrEP as it is dangerous, and that may be concerning. I just see how much impact provider messaging was affected when CDC HHS signed on to U equals U and getting us all on the same page. So I think she makes a very good point, getting all of our work from HIVMA to the Academy and other organizations. It's all really important, but if we could have our public health authorities at the highest level put out language would be similar to what we did with the sign-on for U equals U, that would be extraordinarily helpful. So thank you for giving us that comment, Christine. And I'll also mention, Christine had a comment or a question around Medicare policy changes. I believe Andrea is going to be looking up that answer, and may have to respond to her directly later. I'm not sure if she would know it now, but Christine also asked or said, FYI, despite Medicare policy changes, from my experience as a PrEP provider, Medicare will only pay for HIV screenings 3 times a year, 1 with an annual exam, and then 2 times with a code for high-risk counseling. If this is not true, please let me know how I can get the 4th HIV screening a year covered.
This is Andrea. I don't know if Amy knows the answer to that. I do not, but it's something I will definitely follow up on, and we can report back.
Yeah, this is Amy. I mean, I also would want to get more into the weeds on the Medicare specifics, but I would just say in terms of, and this is true of USPSTF, I think we can learn some lessons for the implementation of the HIV screening grade, and that was taken up by Medicare. And so, but with USPSTF recommendations, there's kind of this like flexibility given to payers that says you have to do this, but with appropriate medical management. And so on the HIV screening side, we've seen, at least in the private insurance market, that appropriate medical management, it applies also to how many tests per year. And so for some plans, for instance, they only say you get an annual HIV screening pursuant to the HIV USPSTF screening grade, and anything else is diagnostic. And yeah, the plan will cover it, but with cost sharing. So I suspect that's what's happening in the Medicare space, but as Andrea said, we'll have to look into that. I will just say, because we didn't say it explicitly, the USPSTF grade for PrEP does not apply to Medicare. It's like a different piece of mapping on the ACA provisions in USPSTF. And so unlike the screening USPSTF grade, which did apply to Medicare, and Medicare did a coverage determination on that, PrEP does not. And so, Truvada or the now Truvada and Descovy are part of the ARV class. So because Part D, the HIV class is a protected class, it has to be covered, but we don't have that same corollary in Medicare of it's got to be covered without cost sharing. So I just want to put that, there's more advocacy too in the Medicare space. It's not it's not directly applicable to Medicare, but I still think we can use the USPSTF recommendation to try to push for better Medicare coverage and lower cost sharing for it.
And let me jump in real quick. I know we're at the top of the end of our conversation at 10:15. I know Mitchell has wants to promote the upcoming webinars that are also happening this week around PrEP. It's a very PrEP-heavy webinar week. We also have Peter Staley, who wanted to speak to the HHS versus Gilead lawsuit. If we could unmute Peter so he can do that. And maybe in the meantime, while we're unmuting Peter, Mitchell, do you want to talk about these upcoming webinars real quick?
Sure, happy to, and just taking my mute.
Ooh, your connection's a little dicey.
Jackie, well, we're getting Peter. Oh, you have it, perfect. So you see the upcoming webinars, and as I think Jim said at the very outset, and as you clearly, can you hear me right now? How's this, Jim?
It's much better. Thank you.
Oh, good. What I was saying is Jim, you said yourself at the very outset, it's complicated, and you certainly saw that unfold for the last 75 minutes in terms of PrEP access in the U.S., in terms of what PrEP, how to pay for PrEP, and actually even to Amy's point, what is PrEP? This was the first of 3 webinars this week, so it's a very busy week. I will highlight that all of them will be recorded and archived with slides, so if you can't make them, fear not. But following on today's, this coming Wednesday in 2 days' time at the same time, 10 a.m. Eastern, there's going to be a special webinar on trial design. As you will clearly know from the conversations here, FTAF was not approved for people at risk of receptive vaginal sex, as the FDA said. And we will have Jeff Murray on from the FDA to talk about the post-marketing commitment that the FDA put on Gilead to conduct an additional trial in cisgender women. We'll also have Yvette Raphael from South Africa, who leads one of the co-leaders of APA, Advocates for Preventing HIV and AIDS in South Africa. And she, along with others, co-convened a meeting just last week, an advocates conversation about next generation trial design. So we'll explore how we might understand about FTAF for cisgender women. And that's Wednesday, 10 o'clock. On Friday, a little bit later, and apologies to those in Europe and Africa and Asia, but at 1 o'clock Eastern time, we'll have leading pharmacologists, including Craig Hendricks, from whom you just heard earlier today, but a number of people working in pharmacology to talk about the science behind the safety and efficacy of today's and tomorrow's PrEP drugs, to really try to understand what advocates might need to know about what pharmacology, pharmacokinetics, pharmacodynamics might mean to understand PrEP in various populations. So just want to flag those calls to kind of expand this conversation more broadly. And thank you, Jim and Kathy and everybody for today. But hopefully now we might have Peter unmuted.
Are you unmuted, Peter?
I've never heard Peter so quiet.
Seriously. Yeah, it looks like, oh, Peter, it's because we don't, Peter, if you could type in your phone number. We don't have your name in the list. We just have your phone number. And we can get to you. We want to make sure we get to you. While we're doing that, if any of the panelists have some closing comments, from Craig to Tim and Amy to Andrea.
This is Craig. I'll just add this in response to Christine's comment before. I'm continually struck by how confusing to providers all the safety stuff is, and it's Christine was very careful to identify the sources of the information that she's getting about the quotes danger, close quotes, of TDF, and so I appreciate Jim's response to that, because I do think this is going to require some attention to look at the quality of these systematic reviews, because as time has evolved, we get to this. We're in a period where the boosted tenofovir prodrugs are more and more rare, and I think that's probably going to be fully extinguished, perhaps in a short period of time in the treatment setting. But I think, in the meantime, it remains very important. And it's been remarkable to me how very, very rapidly TAF completely replace TDF in treatment settings, including in pregnant treatment settings, which to me is quite remarkable, because I just think that the strength of the data, especially outside of boosted, and maybe the issue is that there hasn't been really good data for boosted versus not boosted, and that really was, I think, one of the real advantages of the recent Andrew Hill review that I had included. In fact, David Hardy had included that. So I think a high-level national, international review of this would be very helpful, so there can be a clear, unequivocal message. And I think it's going to boil down to the same sort of thing we see with PrEP, which is, I think, much more clear, is that there are a handful of statistical differences. A few of those have clinical importance in some subsets. And I think it's important to drill down through several levels to sort through that. It's a lot to do in a webinar like this, but hopefully we're able to identify some of the more global issues that are helpful and continue the national and international dialogue. Thanks.
And thank you, everybody. Since we are running low on time and Peter has now been unmuted, Peter, give us the skinny.
Yeah, real quick, Tim is right. Oh, can you hear me?
Yes.
Great. Tim is right. It's going to take at least 2 years for the United States versus Gilead case to come to what would likely be an out-of-court settlement before it actually went to trial. But the potential here, according to the Financial Times, did an estimate that back royalties on Truvada PrEP could amount to about $1 billion. And given the case that was filed by HHS, which said the violations were egregious, they are asking for treble damages. So if the final settlement were for about $1 billion in back royalties, that would end up being $3 billion paid that Gilead would owe. The question is, we know that the back royalties, that we don't need congressional approval to plow that back into HIV/AIDS programming at the CDC. Technically, it would have to be categorized as research, but pretty much anything the CDC does on HIV/AIDS can be categorized that way. They just have to collect a little data. So that $1 billion in a couple of years of back royalties could go directly into HIV/AIDS without a lot of lobbying on our part. It's a huge question mark about what happens with the penalty amount, the extra $2 billion. It is actually, there's no law about it. So there might be a treasury grab for that. AIDS activists will definitely have to lobby to plow that back into HIV/AIDS. It might end up in the courts as to how that gets spent. And then there's the future royalties, which would come out of Descovy, because they have a patent on that as well. And that could be a bundle of money that would constantly go into CDC HIV/AIDS programming. And we're hoping would likely fix our 340B problems in the future. Because if we could get, a doubling of CDC HIV/AIDS funding, we could plow it into a national prevention program, not just PrEP, but treatment as prevention, etc. And U equals U, and really make a difference with grants to all the ASOs that make up for the 340B hit that might come in the future. That's it.
Excellent. Thank you, Peter. Well, are we ready to close it down, Jim?
I think we've done good. We've gone a little bit over, but we saved some of the juiciest stuff for last. So thank you, Peter. Thank you, everyone else. We recognize that this is indeed incredibly complicated, and we indeed cannot figure it out in one webinar. There's a bunch more this week to check out, including the HHS one on Friday and the 2 others that AVAC is part of. And then I think we're going to need to continue to have these discussions. There's just lots of really complicated ethical, challenging things to consider in this very dynamic landscape. So we look forward to having those conversations, and if folks have ideas, feel free to reach out to any of the presenters today or myself, and we'll set up another call, find another way to get information out and have more discussion. Kathy, you want to have the last word?
Well, just to wish everyone a great and productive week, and we certainly appreciate you joining us this morning. Thanks so much.
Thanks all.
Bye-bye.
Bye-bye.